So we will have a very interesting program this morning, but first I will invite you to join the GIEQs quiz for our question. I think I will read now the answers. So which of the following statements is true? Most peri-pancreatic collections need an endoscopic intervention. In most cases, an endoscopic intervention for peri-pancreatic collection is possible 2 weeks after the onset of pancreatitis. The benefit of lumen-opposing metal stents over plastic stenting is mainly seen in patients with walled-off necrosis, or a lumen-opposing metal stent for drainage of peri-pancreatic collections can stay in place for life. So please join the quiz and give your answer. But first, I give the word to Professor Arvanitaki for her presentation.
So thank you very much. It's a pleasure to be here in this exciting event. And we will go through all these questions. So I think it's very useful to have the lecture now. So I will talk about the management of peri-pancreatic collections that I mostly focus on acute pancreatitis. So if we go, we see the timeline of a patient with acute pancreatitis. We usually have this division between less than 4 weeks and more than 4 weeks. In admission, the patients will have, with acute pancreatitis, will have an acute necrotic collection and maybe acute fluid collections, which is mostly necrosis of the tissue. And you have these collections that are not at all organized. And then when time passes, you will either have a resolution, either you will have a development of acidosis, which is a collection with a well-defined wall in almost liquid content, which you also see in patients with chronic pancreatitis. And also another possibility is the development of walled-off necrosis. So this is all this necrosis that has been organized, encapsulated, liquefied. There is a wall, there's various degrees of solid debris, and this is the most frequent outcome of acute necrotizing pancreatitis collections. So when we have these collections,
because I mean, if there's an infectious problem, either after or already right now, the treatment of that is drainage. It's not antibiotics.
True. Well, you have targeted. You will have targeted antibiotics.
Well, you can, but if there's an infection, I mean, if this patient, after a successful drainage, will develop signs of infection, of course, you can give antibiotics if it's Saturday evening, but I mean, the next step would be to do necrosectomy and optimize drainage.
It's true, but
anyway, just I mean,
no, but
by all means,
I understand your point. So that's the final treatment for the patient is drainage. But but if the patient is not doing well, then in the meantime he will have to receive antibiotics, and then it's interesting to know what kinds of microorganisms that were inside and if they respond to regular antibiotic treatment. So first thing for the deployment, so we can maybe zoom in a little bit on the position of the hands and what I'm doing here. So for the deployment, first thing that I do, of course, I use the Doppler to check whether there are any blood vessels. There are no blood vessels here in the neighborhood. And then I check just the position of the axials. So the track that the axios is following. And once I'm happy with the track, then I can ask the nurse to attach the electrocautery. Yeah. We are using, for settings, we are using a pure cut. I don't know if you also use pure cut.
Yes.
Some people are using endocut, but the pure cut is the recommended setting. It's 100 watts, effect 5.
Yeah, the same.
And so important to know, and this is the case for all kystrogastrotomes, do not push and activate, but just stay a little bit above the wall, then activate and then go ahead. And that's the best way to get in very easily. Show it here.
And this is especially important for gastroenterostomy, I feel.
Yeah.
Then it's very easy to push the wall away.
Yeah.
That should be good.
Can remove the connection, so immediately remove the connection, so that there is no risk that accidentally you would push on the on the yellow pedal and cause damage of the contralateral side. So now I'm well in. So this was the first step. It's really mentioned here on the Axios device. So step 1. Then I lock, and I remove this yellow lock. Then I unlock here. And then normally with my hands I do like this to open the stents. You will see it opening now.
So you're opening the distal flange.
I'm opening now the distal flange. This is step 2 of the deployment. And I think I will have enough space to do this in one movement. Sometimes if you have small spaces, you really have to do it in another way. You have to go back from step 2 to step 1. Yeah. And it's very important that you know how to deploy also hot axios in small spaces before you go to drainage of small collections or bile duct, for example. So, okay, I'm well in. You see that the distal flange is completely deployed. And I'm now pulling back. So this is step 3. I still have the nice EOS image until I see this curved, so I see that the position of the distal flange or the shape becomes a little bit curved. Yeah. When this is the case, I lock again, I unlock here, and then I just open my proximal flange in the channel of my endoscope.
So you don't use endoscopic vision for that?
No.
EOS guided method.
Yeah.
It's the US guided method. So in the beginning, the company was recommending to go for endoscopic visualization of the black marker, which I will show to you. But it's dangerous because, okay, you see that I'm very close to the wall. I don't see my black marker now. And if I would change the position endoscopically, it might be that I just pull out the whole axial stent. So I think it's just more safe to do it this way.
It's very easy. If you use the EOS method, you don't have any endoscopic view.
Yeah.
If you use the endoscopic method, you lose the EOS view.
Yes. So I think
it works both ways, but I think the method Peter is using is the one I'm using as well. I think it's easier.
I think it's easier. It's a preferred method. But in case you would lose visualization on the EOS image, you still have this backup that you can deploy the proximal flange, the second flange endoscopically. So now I just unlock here, and I will push it out of my endoscope while making a little turn. And sometimes I have to shake a little bit to really deploy the stent.
At some point you do need to pull the scope back, otherwise there's a risk of completely deploying the stent inside the cavity.
This is a stressful part.
This is a stressful part, yeah, indeed.
Yeah, but you can see the endoscopic view.
Opening.
You have that? Yeah.
So I'm now doing this movement, and often I need to do it several times, especially for the 20 millimeters. Sometimes you really need to do this movement to safely deploy the stent. So you see it nicely draining.
Yeah.
So and then the next step will be to place this double pigtail. I don't think that there is a need here for a nasocystic drain for lavage because it's not infected.
Would you only do it in case of infection?
I would mainly do it in case of infection,
Okay.
So if there is really a lot of pus coming out, then I would tend to rinse it with 500 milliliters of saline for 24 hours, and or maybe 48 hours, and then we remove it. So now I will use a diagnostic catheter with a wire.
You keep the same scope.
I keep the same. I don't change scopes. No. And a 7 French stent, which can be very small, just 5 centimeters, because the only aim is really to prevent the axios from blocking.
And you're going to use the endoscopic image now?
Purely endoscopic.
Check with X-ray, I guess.
And then I check with X-ray, of course.
No, but no more US imaging, that's what I'm saying.
No, US image you can in fact remove the US image now and go for endoscopic view only. I can do this like this,
Marianne, in the meantime, I have a question for you regarding presentation. When you decide to use the nasocystic drain and you opt for hydrogen peroxide treatment, can you give us any tips on that?
We don't do this.
Because you mentioned it in your
no.
presentation.
These are the latest, this American publication.
Yep.
We did it in the past a bit empirically, but we use mostly diluted isopetadine to have a local antiseptic action.
And that is a continuous, there's just an IV line that is open, or not an IV line,
yes,
but
we put the line with perfusion, 500 or 1,000 per 24 hours of saline, and we also put some bolus, 40 ml, just to have a bit of pressure there to move around things. We have to take into consideration if the patient has gastric outlet syndrome, in this case, not to really fill up his stomach. So we put a nasogastric drainage with a concomitant enteral feeding. These special nasojejunal tubes, and we also take care of all the other fluids they will receive, because it's still a lot of fluids.
And then you go back 84 hours endoscopically to check if it's better, or you do imaging to decide?
So after the first necrosectomy technique, necrosectomy, we'll put a nasocystic catheter to do this lavage with the bolus, and then we will go back after 4 or 5 days with imaging.
Okay.
And then we will also clinical symptoms, findings, CRP, decide if we go back or not. There's still not very good criteria to determine this.
Yeah, that's why I'm asking you.
We still do not.
Because you said first necrosectomy and then you decide nasocystic drainage?
No, first necrosectomy and nasocystic drainage. Usually,
but you first you don't, for example, in this example, when you put the lamps, you never immediately put a nasocystic after the lamps.
Yes, we do. Okay. Yes, we do. So when we have a lot of debris and we decide to put alarms, we will. If there's more than 30% of debris, we'll put a nasocystic drain.
Before you do the first necrosectomy?
Yes. This is the drainage plus the nasocystic, and then we will go back if things are not optimal, and then we'll do necrosectomy, yes.
And after what time? After a week or?
Something like that.
Yeah,
we will probably go within a week.
Endoscopic marker at, yes, okay. So we're just waiting now for the double pigtail.
Okay.
It's the final step.
So
thank you.
With that, we will end the live session, and we still have some minutes to declare the winner of the quiz. So we will first see which of the following statements the most people said the third statement. So the benefit of lumen-opposing metal stents over plastic stenting is mainly seen in patients with well-off necrosis, as was shown in the case, I think. And our winner is Thomas Vasilakis. So congratulations. And please keep following the symposium and join us online with the quiz and also the Q&A. Thank you very much for your attention.